There we go. Thanks for doing that too. I was just about to do the same thing. I think when Joe left, the recording stopped. So, um, let me. So I am stop sharing my screen so that I can introduce. So thank you all for being here. Today's hot topics. Hot topic really is on rare diseases in health data, and so I'm excited to have a couple of presenters here. Well, I guess a few actually, to share some information about their experience using administrative healthcare data to research or identify rare diseases and also sickle cell disease, which I think qualifies, but I'm still figuring this out myself. So without further ado, let me go ahead and introduce to you all. First up, I think we're gonna hear from Erica Barnes, the Executive Director of Minnesota's Rare Disease Advisory Council, and Samad Qureshi. I hope I pronounced your last name right, Samad, is a PhD student at the University of Minnesota, and they are gonna share some information with us that I will put on screen right now because I have your slides. So give me just a moment and I'll let you all take it away.
Thank you. Thanks so much, Charles. And thank you so much, Nato, for letting Samad and I come today and present on a topic that is very, very near and dear to my heart, the rare disease community and the rare disease patient population, and some of the work that I've been doing with Samad to better improve our understanding and identification of rare disease patients. As Charles said, I'm the Executive Director of the Minnesota Rare Disease Advisory Council. We are an executive branch state agency in the state of Minnesota, just newly minted. Previous to being a state agency, we were legislatively formed and we were at the University of Minnesota, which is where I met Samad. Literally bumped into each other in the Caribou Coffee at the U and became fast friends because he likes to solve problems. And so we'll talk a little bit about the work we've been doing. On a personal note, I became involved in the rare disease community due to having a child who was diagnosed and unfortunately passed away from a rare disease. This drive to understand and characterize the community better and improve care is very, very important and personal to me. So next slide. So forgive me, I don't know how many of you have familiarity with rare diseases kind of on this webinar, but I wanted to just level set a little bit and give you just a few facts and statistics quickly about rare diseases to just level set. So disease is considered rare if it affects fewer than 200,000 people in the US at any given time. This is a deceptively simple, straightforward definition, and it's a prevalence definition that was really defined by the FDA. And that's the US definition. There's different definitions depending on what country you're in, slightly different definitions. There are roughly 7,000 rare diseases, and they're very heterogeneous. They span all biological systems. So again, because it's a prevalence definition, a rare disease could affect any biological system. They're also not so rare. Despite multiple etiologies, some of them do have commonalities. About 80% of all rare diseases have a genetic basis. The majority have pediatric onset, and the majority are chronic and medically complex. When taken all together and considered collectively, they affect about 1 in 10 of the general patient population. Next slide. And in terms of rare disease, if you look at rare diseases collectively, there's a lot of gaps in the care and patient management. And I kind of broke these up into 3 buckets: diagnosis, management, and treatment. And I want to go through some of the highlights for that. So in terms of diagnosing a rare disease, there's a significant delay in diagnosis. So the average patient with a rare disease waits between 7 and 8 years to receive a diagnosis. There's very high rates of misdiagnosis, average 2 to 3 times a patient is misdiagnosed while they're going through that journey. And the average rare disease patient sees 8 medical professionals before they eventually get a diagnosis. So as you can see, that's a very high level of healthcare utilization, even prior to being diagnosed in the diagnostic odyssey. And then even in terms of management, managing care for a rare disease has a lot of challenges and there's a lot of gaps. Often care for rare disease patients is fragmented across healthcare systems. Many rare disease patients see physicians in one health system. You know, in the state of Minnesota, it's not uncommon for me to hear a patient say, I get some of my care at Mayo, some of my care at the University of Minnesota, and I go out of state for some of my care. And the reason for that is the limited number of specialists who have knowledge of particular diseases. In addition to that, there's some payer network barriers. Sometimes this can limit the ability of a patient to get to the appropriate specialist if that specialist is not within their network. So management can be a real challenge. And then treatment is also, there's a lot of inequities in the treatment. So historically, there was a lower level of investment and interest in rare diseases. And the outcome of that is that roughly only 5% of the 7,000 rare disease communities have an FDA approved treatment. And the quote that I have here is, you know, just one of my favorite quotes, because it is so true that families affect, it was said by Abby Myers, who founded NORD and is the mother of a rare disease child. She said, families affected by rare diseases represent a medically disenfranchised population that falls through the cracks of every healthcare system in the world. Next slide. So I'm not going to spend a ton of time on this slide, but it's a little bit fascinating. And the point of this slide that I want to make is that even using the term the rare disease community, historically, that was not a term. This is kind of a new concept. Historically, rare diseases, you don't see that in the medical literature except as a descriptive. You certainly don't in the medical literature see any allusions to the rare disease community. You know, historically, the term therapeutic orphans was used by a pediatrician who was lamenting the fact that pediatric drug development was, there wasn't a lot. And so he used the term a therapeutic orphan, meaning anything that's neglected by medicine. That term kind of got co-opted by the rare disease community. So the reason I bring that up is sometimes you'll hear a reference to orphan drugs or orphan diseases, and that's now sort of synonymous with rare diseases. And it really wasn't until the passage of the Orphan Drug Act in 1984 that the definition of a rare disease was firmly established and the community started to kind of coalesce together and identify collectively. So you may have, you know, metachromatic leukodystrophy like my daughter, and you may have cystic fibrosis, but you're also part of the rare disease community. And that was really because of the incentives and the FDA's work to incentivize drug development for rare diseases. But the healthcare system has been slow to recognize the rare disease community as a subset of the healthcare population and to take steps to understand its collective impact on the healthcare system. And that's really encapsulates what Samad and what our project has really been all about. So next slide. So it was sort of because of this recognition that the state of Minnesota, that a grassroots coalition that I was privileged to lead in 2019 formed to pass some legislation to form the Rare Disease Advisory Council in the state of Minnesota. And we're charged with being a policy and information resource for the state. And our vision is a state where every Minnesotan living with a rare disease has access to timely diagnosis, coordinated care, and individualized treatment. And so that is really what drives the council, and that's what drives our work. I really, again, I clearly like quotes. This quote by Donald Berwick, who is the gentleman who established the triple aims of healthcare. He said, only when a patient population is specified does it become possible to know about its experience of care, its health status, and its per capita cost of care. So really, again, thinking through that need to specify a population and characterize it. So next slide. So how do you do that? That obviously is the question. How do you look at a patient population collectively? How do you extrapolate information? And how do you make some assumptions and really with the goal of improving care? And so the solution that we want to talk about today, and I'm going to pass it over to Samad, is the use of health informatics and data applications to try to improve care. And Samad and I have worked on two projects. One is a population health analysis, where we use ICD-10 codes and semantic search And then the next one that he'll talk about is developing rare disease ICD-10 code categorizations to be able to find those patients. Samad, I'm going to hand it over to you.
Awesome. Thank you, Erica. So as Erica was mentioning, a lot of our journey with the rare disease community and kind of helping to understand where they fit into the healthcare system starts with this early identification. And we really need to understand how do we characterize this population in many different ways. So through identification, at least what we can do is start shining a light onto who these patients are and what are their patterns of behavior in our healthcare systems. And in order to do that, we attempted to, as Erica mentioned, the first one was a population health analysis, which I'll go through, and then our current project that we're actively working on and hoping to, have further collaboration, nationally on. So next slide. So first, we'd like to just kind of level set with the audience, on where we are with our understanding of what ICD-10 codes are and how they are used to characterize a population. So just at a high level, ICD-10 codes are often used in the medical billing system, and they are used by various providers to kind of submit the services that, for their patients to kind of get, get the compensation that they need. And from a health they have a very different application from like a health informatics and population health standpoint. And in that standpoint, we're looking at it from a disease perspective. So when we are trying to look at these patients, a lot of times the note-taking mechanisms that are utilized can be varying in a lot of the different healthcare systems that they go into. So we wanted to find a centralized, standardized method. And so that's one of the reasons that we selected this as kind of a vehicle to help us drive our analysis. And so we wanted to understand this standardized universal structure that's adopted by a lot of different healthcare systems that we're seeing. Fairview, UMMC that we work with closely definitely uses it. And so that was one of the driving factors for us to kind of utilize it and figure out, what can we do to extrapolate some of the information from these codes that are being submitted on behalf of our rare disease patients. It can also capture some of the symptomatic details of patients, as well as measure some large scale diverse types of services across multiple different healthcare providers. On the right-hand side, from like a population health perspective, there is some limitations when we're assessing the population. And then Erica will talk about some of the applications as well in like in the medical system, how they're actually applied in our tools as well. But basically, with the ICD-10 codes, there is a limited amount of codes. And, with its application, that also kind of creates a little bit of restriction on what is available in terms of a population health analysis that we can be looking at. There can also be variability. No one provider, will kind of code in the same exact way. So we'll have a lot of variability that we see when we kind of look at it. There's also other types of codes that exist, and we're very well aware of that in the in our various different healthcare systems, CPT codes, HCPCS codes, all of those different types of codes. We wanted to hone in on one, kind of build a profile around here, and then kind of look at, what can we do with the measurement. And I'll talk a little bit later about some of those limitations and kind of how we are planning on incorporating them as well. And again, there is just a general, lack of literacy around the codes. The codes were released in 1999 by the CDC with a version that was implemented in the United States. And the uptake has been slow with these codes in the various different healthcare systems, and people are still learning. There's around 80,000 codes total. And so just to kind of understand, what are the the breadth of codes that exist out there, and what are the proper codes for coding with our rare disease patients. That's kind of what the challenge is going to be when we're doing some of these analyses. So we wanted to be as upfront as possible with them. Next slide. So Erica, I can let you talk about a little bit of the implementation if you'd like.
Okay.
And I can chime in as well.
Thank you, please do. So there are technical challenges to using an EMR record, of course. So we know that you can try to use records, you can try to use ICD-10 codes, but there's always going to be challenges. Nothing is a perfect system. So some of the challenges we wanted to call out and identify here is when we're talking about using EMR records to get to an earlier diagnosis so that we can have better care management, rare disease patients are fragmented. They're a fragmented patient population in a fragmented healthcare system. So it is very difficult. If you're looking at, if you're using EMR records and you're using one healthcare systems, you're going to miss information because those patients are likely, as I said before, going outside of one healthcare system. Again, same thing, specialty visits, that is really the driver for that. There may be one specialist in the world that a patient has to see. Another challenge to using EMR records and ICD-10 codes is symptomatic coding. So you don't necessarily know. So for example, my daughter initially was diagnosed with hypotonia, and that's really a symptom, right? That's not a diagnosis. So there's challenges. Also, there's challenges in determining the collective impact using EMR. And this is kind of duplicative to the other slide, but when we first started this project, I thought, oh, we'll just find all the 7,000 ICD-10 codes for the rare diseases, and then we'll do a collective impact study, and only to find out there's only 500 ICD-10 codes for the rare diseases. Often, there's an umbrella code, and you have to sort of try to extrapolate which umbrella code fits a rare disease. Another thing that's challenging and is so fascinating to me is the fact that providers sometimes bill to ensure comprehensive services, right? If a disease doesn't have a specific ICD-10 code, there are some diseases that have autism as a very salient characteristic. So physicians will bill autism. So there's a lot of challenges to using the record. That's okay. And there's also various names for rare diseases. So, and I'm looking at the time, so I'm going to throw it back to Samad.
Yep.
I'm sorry, I'm talking kind of fast.
No, absolutely. So as Erica was mentioning, we are, with all of these challenges in mind, we really wanted to kind of assess in as comprehensive of a way as possible with the existing data that is available to us. So our main focus, and on the next slide, I can talk about it, just to jump into some of our analyses. So the first stab at the analysis that we tried to do was regarding a population health analysis using the ICD-10 codes. So as Erica mentioned, and kind of one of the things is that there is missing codes that are related to the rare diseases. And so when we're kind of understanding the healthcare system, we have to kind of figure out what are the codes that a provider could potentially use in order to identify or characterize this disease, or a disease that's similar to it, or in a way that would be adjacent to what the disease's symptomatic relationships are. So we worked to, from the 80,000 list, I worked with a machine learning specialist, one of our previous collaborators, Rohit Marakanda, to create a live list of ICD-10 codes that can be implemented to identify rare disease patient populations within a given system. And this goal was, with this live list, it had more than from 500, we increased it to 3,000 codes that could potentially be the identifiers for these rare patients within this healthcare system. And the way that we did it was through this process called semantic search, where it's a word-based machine learning process where you use the specific word and then adjacent words that would be within a closer relationship to identify codes that a provider could potentially use for the different conditions that we were looking at. And this was all with the end goal of better understanding to characterize specific aspects of care management and patient management within a healthcare system, and understand where those patients were and kind of how they were impacting as well. So on the next slide, please. So the process that we followed is that we went to our, we went through our direct resources within the rare disease community. Erica mentioned one of them, the National Organization on Rare Diseases. They keep a very active live list of diseases and conditions that are up to date. So we went there, used that as our reference population, and looked at all of the rare diseases that were available to us that are currently documented and have, specific support through NORD as well. And so we wanted to take this full list of the 7,000, and we used this machine learning process process to extrapolate this list and figured out this coding list of 3,000 codes. And then we took those 3,000 codes and worked with a team within Fairview, within one of our physicians that we worked with, Dr. Orchard, who is an MLD specialist and has done a lot of amazing work at our UMMC hospitals. We worked with him to really go in and do a comprehensive analysis of identification of these rare disease patients. And what we found is that with the original list where we were just looking at the 500, we were like kind of capturing just a small cohort of the member population or of the patient population that we're looking at. We were able to kind of look through and kind of broaden that scope and bring in a lot more rare disease patients. Obviously, one of the limitations here is that they're not exact precise codes. So we had to go through a lot of different processes of cycling and kind of deletion to try to figure out, okay, where are the potential risks for rare disease patients, which are not rare disease patients. But again, that is where we are working with our specialists and our providers to kind of understand, okay, this is the population that we identified. And then within that population, here's the subset that is accurately, with a rare disease or rare condition, or potentially could be a misdiagnosis for a rare condition as well. So gives us a more, a larger scope of evaluation as well. And on the next slide, please. So the last thing that I'd like to just kind of quickly discuss, and I know we're probably at the top of the hour here, is just our engagement assessment, rare disease enhanced assessment model that we're currently building out and working on. So the goal of this model is to really improve on our previous initial analysis. We're trying to improve our engagement with rare disease patients and understand kind of those symptomatic diagnoses relationships that Erica was talking about, and how do we build those relationships out and cohesively kind of build disease profiles to capture these rare disease patients. So with this, as on the next slide, please, I can kind of rush through this. So our goal with this is going to be to understand in the earlier phases, obviously a lot of the diagnoses are pediatric diagnoses. We want to look at what are the initial diagnoses that our rare disease patients are coming with? What are those misdiagnoses? What are those symptomatic diagnoses that they have? And how do we use those to build out these disease profiles? So this will help us in turn reduce time to diagnosis, enhance our diagnostic process, and increase our connectivities between our general practitioners and specialists, those 8 that Erica's talking about. Maybe we can reduce that down to maybe 4. That is our dream, to kind of reduce that down to, so that the rare disease patient is going to see their general practitioner. Maybe that general practitioner has the knowledge, we increase that knowledge and then help them get connected to the right specialist to start receiving their care sooner, and that has a massive downstream impacts on the patient's care. Next slide, please. So this is just a high-level overview of what we are currently working on. Erica and I have gone through over the last 3 years since 2018, working with a very dedicated team to search over 80,000 codes and kind of work with using the semantic machine learning process and other processes to extrapolate out specific disease profiles for 21 diseases that we selected that we saw had support and impact in the rare disease community. We're also at the same time working with community connections, our community partners, rare disease organizations, to really work and validate our selection criteria on how we're looking at the different symptoms and really understanding those symptomatic relationships from the specialists themselves, because that shows us that we are kind of in line with what they are visibly able to see within the rare disease community. Because at the end of the day, this is supposed to be a decision support tool that is supposed to help provide this guidance to our general practitioners and get them connected to these specialists. So we're really trying to build this layer of community through the use of our healthcare data that's available to us, and really kind of help support and raise up the rare disease community as well. We are kind of doing this with, once we're done with our validations, we're also using various different data mining and statistical techniques to understand what is the predictive capability of using these diagnosis codes to figure out how do we kind of correctly identify these rare disease patients, and creating a rare disease matrix, really kind of end-to-end evaluating where that initial kind of risk for a rare disease patient kind of falls. Next slide, please. This is just a quick list of all of a quick list I say, but a lot of work that we've done over the last 3 years to kind of connect with all of our different organizations and community partners, various of the diseases that we are kind of looking into right now and really trying to understand their full disease profile, and then jumping into kind of our data evaluation, hopefully towards the end of this year as well. Next slide. So Erica, I can let you take over this slide.
Yeah, so to kind of pull it all together, as Samad said, you know, the work we're trying to do is can we use ICD-10 codes and sort of this diagnostic odyssey that patients take and have a predictive analysis so that patients can get to the care that they need sooner. And of course, the goal of that, the end goal is to increase care management. So some of the value of collaborating and some of the power, if all payer data claims was something that we could use, would be you know, using data claims is so much more powerful than a single hospital EMR system. Again, going back to the fact that it's very difficult to find rare diseases just looking at one system. It helps us see this system as a whole. All payer data claims also allows us, again, a broader view to have more insights into the patterns of behaviors for the rare disease. Whoa, patient population. I lost my slide. But really, it's okay, because we should wrap it up anyway, because I'm talking way too long. But all of this, really, the goal is, how do we use big data? How do we use the data out there to better manage care for patients? And I think it's so important to also say that better care equals reduction in health costs and utilization. So really being able to look at this data and use it for meeting that goal of helping patients get to the care they need faster and helping the system work better for rare disease patients. And with that, I will turn it back to Charles, I think. So thank you all so much for letting us present.
Yeah, thank you, Erica. Thank you so much. That was really great and interesting. And I appreciate your patience with me while I accidentally touch things and then cause the presentation to move around. So thank you all. If you have questions for Erica or Samad about this particular project, please feel free to put them into chat or raise your hand, I suppose would be another way that we could do this. I will kind of come back to some questions, maybe given time. I think maybe we'll go to the next presentation first. I'll stop sharing so that Astrid, you can share your screen. Let me make sure that you're able to do that on our next presenter. Well, Astrid, are you able to share your screen by chance?
It says it's disabled. So if you just want to pull them up, it will be.
Okay, I can do that. Or Norm, can you make Astrid a host? Able to, it turns out. Okay. So maybe that will happen. If not, I will look for the others. In the meantime, Astrid Knott is our next presenter, and is a research scientist at the Minnesota Department of Health, working on sickle cell disease research using healthcare data. So let's, like I said, let me find that presentation real fast, and I will put that on screen for us. I'll do my best to not interfere while you're talking, Astrid. All right. Can you, oh, probably not. Let me,
I will just start talking.
Yeah, there you go.
As Charles said, I'm a research scientist in the health economics program at the Minnesota Department of Health, and I'm going to be talking about sickle cell disease in the Minnesota APCD. Next slide, please. I'll be briefly talking about sickle cell disease and the Minnesota all-payer claims database, and then I'll describe the sickle cell disease population in Minnesota and reflect some on the challenges of looking at a rare disease in an APCD. This analysis is funded by the CDC's Sickle Cell Disease Data Collection Program. Next slide, please. Sickle cell disease is a group of inherited blood disorders in which the hemoglobin in the red blood cells is abnormal and the red blood cells become hard and sticky and look C-shaped, which is where the term sickle cell comes from. It leads to serious complications, including anemia, frequent pain crises, stroke, organ damage, and results in a decreased life expectancy. There's currently only one cure, which is a stem cell transplant. Next slide, please. There is no national data collection effort on sickle cell disease in the US, and so the prevalence is an estimate. We think that about 100,000 Americans are affected by sickle cell disease. It is especially common in people with ancestors from sub-Saharan Africa, Spanish-speaking regions in the Western Hemisphere, Saudi Arabia, India, and the Mediterranean countries. It affects about 1 in 365 African-American or Black births in the US. A recent article in MMWR showed that preventive health measures in children and adolescents with sickle cell diseases are low. The average age of death in a study from California and Georgia was 43 years for females and 41 for males. The COVID-19 pandemic impacted sickle cell patients dramatically. It increased death rates. And sickle cell disease has been part of newborn screening in most states for a while. Minnesota started screening in 1988. Next slide, please. The Minnesota All-Payer Claims Database was enacted as part of a reform package in 2008. Data submissions started in 2009. We currently have about 100 submitting entities, and the APCD covers Medicare, Minnesota healthcare programs, and commercial insurance. And prior to the Go-Bay decision, we had about 95% of insured individuals in Medicare and Minnesota healthcare programs, and 85% of the commercial population. Since 2016, the commercial population is only about 40% of the commercially insured in Minnesota that are reflected in the APCD. Next slide, please. As part of this project, we are working with a number of different data sources. Next slide, please. And what does the APCD add that we can't get from these other data sources is that it's a more comprehensive data source, and it allows us to see all patients or a larger group of patients than any of these other data sources that we have. These other data sources are newborn screening and follow-up, which focuses on a distinct population, or hospital discharge data, which in Minnesota only covers hospitalizations and emergency room visits, or vital records, which focuses on births and deaths. The other advantage that we have is we can follow members over time across care settings and across insurance coverage in the APCD. And we can use that to address various questions, such as the geographic distribution of patients, the receipt of preventive and other care, and spending. Next slide. I think we're 2 ahead. For this project, we use a case definition that was provided by the CDC, and it says a probable case of sickle cell disease is one with a person with 3 or more separate healthcare encounters with the sickle cell ICD code during a 5-year period. Next slide, please. This slide shows the patient population over a 12-year period. In this 12-year period, we found 1,548 sickle cell disease patients in Minnesota. And the size of the population in any given year depends on which inclusion or exclusion criteria one applies. The top line here, the blue line, is anybody who has at least 1 month of eligibility data in the APCD. And as we restrict the population, you can see that the number of patients goes down. This obviously has implications for any research studies that one would conduct. Next slide, please. Another thing we discovered, which might not be a surprise, but is that even though sickle cell patients are heavy users of healthcare services, in a given year, there are quite a few that have utilization but do not have any claims with sickle cell disease codes on them. So what you see here is the top line, patients that have utilization in a given year. And the bottom line is patients that have utilization that have a medical claim with the sickle cell disease code. And one always has to keep in mind this is claims data. Things that get paid get coded. And if the code is not necessary for getting paid, it might not be applied. Next slide, please. This slide shows the age distribution by gender with female patients on the left and male patients on the right. And what is striking about this is that there's very different, excuse me, very different patterns in the population. On the female population on the left-hand side, we see that the first 4 age groups, essentially 0 to 39, are of similar size. And then there's a pretty steep drop after that. Whereas in the male sickle cell disease patients, there's a decrease for every single age group up to age 40 to 49. We think this is partially related to reproductive health care for women and access to health insurance because of that. Next slide, please. This is the geographic distribution of sickle cell disease patients in Minnesota by county, with the white counties having no sickle cell disease patients, the gray counties having 1 to 10, which in the Minnesota APCD, we cannot say how many, and the blue counties showing 11 or more patients. And what we see here is that patients are concentrated in urban areas or in larger cities in Minnesota, but even though 40% of the counties in Minnesota have sickle cell disease patients, but 10% of the counties account for 90% of the patients. Next slide, please. Next slide, please. Charles, can you?
Seems maybe Charles has frozen. I'll just reach out to him.
Oh.
He's yeah, just send me a message. Says something is frozen.
Well, I can describe the last 2 data slides that we have. One of them is on the emergency room visits by sickle cell disease patients in general. There's an understanding that sickle cell disease patients are high users of emergency services. What we found is that about 40% of the patients in a given year do not have a single visit. That's the bottom blue category. Another 20% have 1 visit in a given year. But then we have the top category here in purple or lavender, and it's about 15%, very slightly. And that's people with 6 or more visits, and it actually tops out at over 50. We have people in the data with over 50 emergency room department visits in any given year. And next slide. If we look at the payers for emergency room visits, we see that Medicaid is the predominant payer for sickle cell disease patients for emergency room visits, followed by dual eligibles, and then the commercial population. One thing to keep in mind is that the commercially insured population is underrepresented in our data, as I said earlier, so that category would likely be larger if we had more coverage. Next slide, please. Just to recap, we found 1,548 distinct sickle cell disease patients in Minnesota. There are more female than male patients, and the younger age groups make up the majority of the patients. And the majority of the patients reside in a small number of counties, but there are patients in many counties. Next slide, please. So as I discussed earlier, the APCD is our most comprehensive data set, and it allows us to look at patient level data, which other data sets that we have access to do not. There are challenges, obviously, with APCDs and claims data, and some of them are general, will apply to any of the data sets. Some of them are specific to Minnesota. First of all, one needs a validated case definition, which we were lucky to have from other sources. Small numbers presented a large problem. We're dealing with a rare disease, and any kind of stratification will create small number cells that will create issues in analysis and in reporting out. For the Minnesota APCD, we know that there are certain populations that are missing from our data, such as the uninsured, and some are underrepresented, such as the commercial population. The APCD in Minnesota does not cover, as I said, uninsured, Indian Health Service, the VA, or TRICARE. Other challenges that we encounter is that we have zip codes on our data and not counties. So we need to crosswalk from zip codes to counties. We lack race, ethnicity, and language variables at the moment, but we're working on getting those onto the data. And there are certain regulatory restrictions on the Minnesota APCD, such as we cannot identify providers, which creates issues when you're reporting on a small number of providers or a small number of patients. Next slide, please. The next steps for our project are looking at the utilization of inpatient stays, specialties, services, and preventive care. And we're also exploring linking the APCD with other data sources within our regulatory framework. Thank you.
Thank you, Astrid. And hopefully everyone can, my connection has been finicky, if you can't tell. So I hope I switched my phone. I hope this is working okay. I noticed really quickly, Astrid, that we had a question in chat related to the ED visits that you showed on screen. The question was whether or not those ED visits were sickle cell related or like an all-cause visit.
They were not sickle cell related. It was any emergency room visit.
Any emergency room visit. Thank you. I'll remind everyone, if you have any questions, we've got, it looks like 5 or so minutes left. Feel free to toss those into chat, and I will go ahead and kind of weigh in here a little bit. I actually wanted to just kind of clarify one thing about the first presentation that I think would be helpful maybe for others. So you all are using the ICD-10 codes and some type of semantic search. It sounds like the ICD-10 codes are in the EMR rather than on a claim record, right? Although you all have kind of laid out clearly what the role of those codes are in the first place for billing. So the question is, is the semantic search relying on like the full string of the ICD-10 diagnosis, or are you all bringing in other maybe free text or string fields that are used in the semantic search that come from the EMR specifically?
Samad, do you want to answer that? That being a little more technical. I don't know if Samad is there still. So I mean, so we did have this discussion, and if Samad joins to answer, I'll let him. He's definitely more of the technical expert. So at this point in the project, we're kind of in that first phase. We were just using ICD-10 codes, and we used instead of looking at the EMR record itself, partly because of capacity and partly because, again, to limit that subjectivity with the way that data is entered into the EMR record. So we just kind of kept it standardized with using the ICD-10 codes. And we used, what we did was we searched symptoms that for each disease. So we had an army of volunteers that searched different symptoms that could be related to a certain rare disease. And then we looked for the ICD-10 code. So for example, with children with MLD, strabismus is often a symptom that's coded, as well as hypotonia. And the goal is to get a dictionary together and see if a combination of those codes could help identify those patients sooner.
Yeah, thank you. So let me kind of zoom out a little bit instead, and I'll kind of pose this question to Astrid first. So the question, but this is really to both, to everyone here, is kind of what is the future for the rare disease community in terms of big data? Are there things that you're excited about? Are there things that you all need or limitations that you hope will be addressed in these data going forward? Kind of, if you could speak to that, I'd be curious to hear what your thoughts are.
Sure. Our project is part of a data collection effort by the CDC that currently involves 11 states and excuse me, and focuses on sickle cell disease only. But what it will allow us to do is combining data from different states together and doing analysis on a larger patient population than we in Minnesota have, for instance. And for various reasons, I think Minnesota is probably one of the states with a relatively small sickle cell disease population compared to some other places like California, Georgia, other places like that.
Yeah, and as far as kind of writ large for the rare disease population and looking at the future, just more application of bioinformatics and AI is very exciting for the rare disease community. And it's really the only, I don't want to say only hope, but is really the best hope for early diagnosis for rare disease patients. You know, physicians just cannot be expected to keep in their brain, these very complex diseases. There's 7,000 rare diseases. They may, if they were lucky, have heard about a disease in medical school once. And so really being able to use AI and big data to help do that searching for these patient populations so that we can, potentially have a flag, right, in the EMR record that if there's a combination of certain codes that would flag the physician and say, hey, have you considered, XYZ rare disease? We see that this patient has had, this certain combination of codes. So really, in general, just the rise of AI and better applications specifically for the rare disease community to get to faster diagnosis.
Really interesting, to say the least. I certainly hope it goes well. That's the promise. So I am realizing that somehow my computer and phone have two different times. I didn't know that was possible, but that we are at the end of the time. So let me say again, just kind of thank you to Erica, to Samad and Astrid for taking the time to share some information about the rare disease research using ICD-10 codes and all payer claims data. And we will kind of continue to host hot topic webinars going every other month. I think the next one is July. I'm not going to say the date out loud because I'm not sure, but it is the last Wednesday of July. So look for more information. Thank you all again, and we will talk soon.